Sorry, colleagues and moderator, I'm honored to be here to have the opportunity to discuss with you our experience about the performance of Bladder EpiCheck. First of all, I would like to thank Dr. Christine Mian, our dedicated cytopathologist, who is the soul of this study. And let's go to the point. Why are we so interested in urinary marker? Here you can see the age-standardized incidence of urothelial cancers in some European and non-European countries, and Italy show a very high incidence. Here, and then, on the right, you can see the pure incidence of urothelial cancers in our beautiful, quiet, and small land, South Tyrol, about 1 case per week. So the follow-up of the non-muscle invasive bladder cancer represents a challenge for urologists. It's an important economical burden for the national health system, and it costs more or less 57 euros per capita in EU per year. And constitutes also an important psychological burden for our patients, increasing the anxiety and depression and deeply affecting the quality of life of them. Our patients have to put it with this procedure lifelong. At the moment, the gold standard procedures are represented by cystoscopy and urinary cytology. Cystoscopy allows us to have a direct vision of the bladder wall, but in some cases it's not so easy to distinguish between a carcinoma in situ or a simple inflammation. On the other hand, the power of cytology is represented by the carcinoma in situ. In this patient, we have a very good performance of this procedure. But the weakness of cytology are the pseudopapillary cell groups that can be caused both by benign or malignant lesions, like inflammatory lesion, manipulation of the specimen, therapeutic agents, BPH, stones, and also carcinoma. To this fact, we are looking for urinary markers that can be safe and reliable, but at the moment, no urinary marker had been included in our guidelines, and no one of these has been jumped in our clinical practice. What do we need? What are the demands of a marker? It should provide an early diagnosis if possible. It should show a high sensitivity and a low false positive rate with the aim to avoid unnecessary procedures and with the aim to avoid to miss the disease. Should be inexpensive, especially in this spending review era almost in Italy. It should be easy to perform and, if possible, to provide a certification of our patient regarding recurrence, progression, and response to therapy. Here you can see several urinary markers that have been discussed. Immunocyte is no more in production. At our clinic, we use at the moment the Eurovision, the expert PC monitor, and the Bladder EpiCheck. This is our old flow chart for the follow-up of patients with non-muscle invasive bladder cancer. Our patient was followed with cytology and immunocyte and cystoscopy. Due to the results of cytology and immunocyte, we can decide the timing of the cystoscopy. For the intermediate risk patient, we performed also the FISH, the Eurovision. If the patient showed an aneurysm in 9p21 or in chromosome 3, they were followed as low grade. And if they showed an alteration in chromosome 7 or 70, they followed as high grade. At the moment, we are looking for a marker that can substitute our immunocyte, and to this fact, we are checking our EpiCheck. We conducted a prospective study that included 243 consecutive patients with a mean age of about 73 years. The male-to-female ratio of our series reflects the classical epidemiological data of the literature. It's important to highlight that in this series, we had 11% of the patients had to be excluded due to insufficient DNA, but maybe we can consider this series as our learning curve. About 40% of these patients presented at first diagnosis a high-grade disease, and about 34% were treated with the bacillus of Calmette-Guerin. We had 69 tumor recurrence, most of these, about 60% of low grade. With regard to the detection rate, so EpiCheck showed a good sensitivity, 62%, and if we combine cytology and EpiCheck, we can reach 66%. Cytology showed, as ever, a very good and excellent specificity that could not be reached by EpiCheck. With regard to negative predictive value, the two tests was more or less overlapping. If we combine them, we can achieve 84% of negative predictive value. The positive predictive value of cytologies was really high, about 92%. The area under the curve of EpiCheck was very good, 0.78. If we stratify our patient according to the gray, the sensitivity of EpiCheck ranges from 46% in low-grade patient up to 83% in high-grade patient. And if we combine the two tests, we can achieve a 90% of sensitivity. So concluding, the sensitivity of bladder EpiCheck test is significantly higher than for cytology. It shows a good high specificity that cannot reach the excellent performance of cytology. This marker is also useful in patients with high-grade lesions treated with BCG, patients in which the sensitivity of cytology decreases dramatically. Moreover, if we combine cytology with EpiCheck, we can increase significantly the tumor detection rate, maintaining the high specificity of cytology. And maybe in the future, we could reduce the number of cytology in low and maybe also in higher risk patients. Thank you.
Carolina, my first question is obviously why you have so much bladder cancer in your region.
Tricky question. We don't know. We have only hypotheses. We had in South Tyrol many steel industries. We have the pollution of the pesticides, of the crops, apple.
Okay.
And maybe the pollution of the cars. We don't have an airport. We have to use train or car.
Okay, so
the traffic. We have a
okay, so an airport is good for bladder cancer. I didn't. That's a good one.
Yeah.
I fly a lot, so I'm safe. Most of us here are safe, I guess. So, and the second question is, are you not privileged by a very good cytopathologist? Because are you not privileged by a very good cytopathologist?
Yeah, we have a dedicated one, so.
Because not everybody has that. I think the comments of the German speaker were correct that you should have good cytology, but
we're lucky. We received the result of a cytopathology in 24 hours. We have a direct communication with our cytopathologist.
Yeah, you're very lucky with that.
Yeah.
Okay, any questions for Carolina? Okay, well, thanks a lot.